Okay, everyone, this is our fourth and final lecture for this unit. So we've talked about how we describe the problem in terms of burden and course of disease, how we discover the etiology using distribution of disease, the three requirements of individual association, cause preceding the effect, and altering the cause alters the effect, or supporting evidence such as dose response, consistency of evidence, biologic plausibility, those types of things. And then we've looked at recommendations. How can we impact this particular health outcome, again using data, looking at the quality of the evidence that we have and looking at the magnitude of the net benefit, so the benefit minus the harms. So now that we figured out what we should do, how are we actually going to do it and make sure that it's working? So we're going to talk about implementation and then evaluation. So implementation, or how we get it done, can also be thought of as when, who, and how. And these might not be in the way you would expect them to be used. So let's kind of go through. We're going to start with when. So when we talk about when in public health, we're often talking about when in relationship to the disease or the health outcome or condition. So primary here, so we're going to kind of go down this column, is before the disease onset. So if we're talking about lung cancer and heart disease and other things that smoking contributes to, then we're going to talk about preventing people from smoking in the first place. So this is primary prevention. We're going to make sure that they don't get on that path to poor health. Or if we're talking about STIs or other health conditions that you can get from unprotected sex, we're going to talk about safer sex and making sure that people are using condoms. So primary, you can think of it as it's preventative, right? So it's often called primary prevention. Now, a secondary intervention is either you have the disease, but it's not yet symptomatic, or you have developed some risk factors for the disease. And so we're going to intervene now at this point, right? The cat's trying to get out of the bag. We're going to try to get it back in. So smoking prevention programs, helping people quit smoking before they develop heart disease, lung cancer, lung disease. Screening for lung disease would also fall in that category. When we think about diabetes, which is another really important health condition in our population, screening tests for diabetes to see if somebody's in the very early stages of diabetes, that's one of the things that we do. That's a secondary intervention. Or in the case of unprotected sex and the risks thereof, we might be talking about emergency contraception or getting STI testing to see if you actually got something that you didn't know about. So that's secondary intervention. And then tertiary intervention is you already have symptoms, right? But it's not irreversible. So that would be treatment of lung disease from smoking. That would be treatment of lung cancer even would fall in that category. And certainly for tertiary, for unprotected sex, right, treating those STIs and getting them gone. So that is the when we talk about the when, who, and how. So to give you another example, if we think about COVID-19, it gives us so much rich fodder we can talk about everything in public health through the lens of COVID-19, pretty much. All right, so primary interventions for COVID-19 were wearing masks and social distancing and getting vaccinated. Those were all things to help you prevent infection. Secondary interventions were things like routine testing, so testing regularly even if you didn't have symptoms, which is something that we did here on campus. Everybody had to get tested. Quarantining people who'd been exposed. So, they've been exposed to somebody with COVID, so now we're going to keep them separate from everybody else and wait and see if they're infected or not so they don't accidentally expose other people, or isolating the people who are infected themselves, right? So again, they can't spread it to other people. That would be examples of secondary intervention. And then tertiary interventions would be, admitting people to the hospital, giving them medications, all those types of things. So there are all these different things that you can do, of course, and you also have to think about how you're going to do them, because sometimes people aren't going to be really happy about it. So we're going to come back to that later. So we talked about when. let's talk about who. So that second question, who, is this something that you're going to recommend for everybody, or are you just going to target certain populations? So remember we talked in the previous unit about that improving the average approach versus just trying to get those at highest risk. And so it might be those who are most vulnerable, or it might be those with the greatest net benefit to be gained. So if you remember when we looked at recommendations for COVID-19 vaccination, and we were looking at the slide on myocarditis, which is a potential side effect of the vaccines, although less common than with actual COVID infection. But anyway, we saw that the net benefit was smaller in the youngest group of male-bodied people. It was still significant, but it was smaller than it was in the older folks. So actually in some other countries, because the net benefit to COVID vaccination for the youngest people was smaller, they didn't vaccinate their young people, or they didn't vaccinate their young people until much, much later in the pandemic. And we'll talk about why as we kind of talk about infectious diseases or communicable diseases later in the course. All right, so that's who, that's our second question. And then our third question is how. So the book talks about, and we do basically have kind of 3 different ways we can intervene. So the first is to just let people know, right? So get the information out there, educate people, do public awareness campaigns, put information up on billboards. We certainly saw this during COVID-19. Lots of signage, messaging, TV spots, ads on your socials, whatever it might be, right? Getting the information out there that, hey, these things will decrease your risk of getting sick or spreading the illness to others. So we did that a lot. The second thing that we can do is kind of really encourage people to do something by giving them an incentive. So really motivating them in some way to do this behavior that's going to be good for them. So for example, as somebody who works for the state of Wisconsin, right, and I'm on one of their health insurance plans, there's this Well Wisconsin program. And if I go and like get my cholesterol checked, and I can document that I went to the dentist, and if I do like an exercise program and I show that I did these things that are protective of my health, they give me $150. Right? So that's a motivation to go and do something that is good for me, right? I don't have to do it, but if I do, I get a nice little reward. So that's a motivation or an incentive. And in fact, there was a time during COVID-19 when the state of Wisconsin would give you $100 if you got a COVID vaccine. So, so motivations and incentives, they can be very powerful. And then our third category is obligation or requirements, right? So whether this is a law or a policy or something that says, nope, you have to do this. Like, it's not just we think it's a good idea or here's some incentive to sweeten the pot. Like, no, you have to do this or else we will not allow you to do this other thing. So in the United States, especially, and we'll talk about this more, but we tend to really value personal liberty and autonomy, right? So we value the fact that it's my body, my choice, for example. And certainly of all of these different options, just giving people information and education preserves the most individual autonomy, right? Absolutely. And that's an important value and something we always need to keep in mind. The trick here, the challenge, is that when we actually look at which types of interventions are the most effective, it's the obligations and the requirements. So you can tell people to do something till the cows come home and that it's going to be good for them, but a lot of times they're not going to actually do it unless you make them do it. That's just human nature. So let's take a look at an example of how that kind of played out in the United States in regard to road accidents and traffic fatalities and seat belts. So it turns out that seat belts are relatively recent as an invention. So it wasn't until the 1950s, here in the 1950s, some cars started adding seat belts. Like, that was a new innovation. Saab was the first and others followed. And in fact, it was shown to be really life-saving, right? It really makes a difference in terms of people's ability to survive a car accident. And so then in late 1960s, federal law was passed that required all automobiles to have seatbelts in them. Like, it used to be you could buy a car and it didn't even have seatbelts, like it wasn't an option. So they said, no, all cars have to have seatbelts. And they started all of these public education campaigns, right? So all of these buckle up for safety campaigns saying, you know, it's really a good idea to wear your seatbelt. And now all cars, well, at least new cars, right? So a lot of people are still driving cars from before that law that did not have seatbelts. And so huge public education campaigns. And we did see some improvements in terms of fatalities, but not huge. And you can see it's really kind of variable there. So then in 1984, so around here, New York State was one of the first states to pass a law requiring the use of seatbelts. And it actually is what's called a primary requirement. Like, a state trooper can pull you over just for not wearing a seatbelt. And I was 12 and I remember this, right? And I'm pretty, like, I'm a rule follower. I'm kind of a goody two shoes, but I remember having to get in the habit of putting on a seatbelt. We did not wear seatbelts until that law was passed. Like, I'm just telling you. You know, yeah, I know it's a good idea. Oh, but I'm only going to the store, like, whatever. You know, you just don't do it unless you're told you have to, oftentimes, right? That's just human nature. And so what we see is then, as state after state after state, in fact, every state except for New Hampshire passes a seatbelt law, we see significant declines in fatalities. Now, you might say, Dr. Hall, that is not such a huge decrease in fatalities, but I actually have to tell you that it is, because during this same time from the 1980s up and through, like, you know, the first couple decades of the 2000s, the number of miles that everybody drives has gone way up. So we're actually being exposed to more risk because we're spending more time on roads and more time in cars and driving. And yet the overall mortality rate for the general population has continued to go down. So seatbelt laws have been very effective, and they were more effective, right, than education campaigns alone. And certainly, like, it wasn't until a federal law was passed that all cars even had to have them. So those obligations tend to be very powerful. I need to get my glasses because now we're going to talk about laws that had to do with smoking. So this has been a huge public health success, and the book talks a lot throughout this chapter about all the improvements we've made in terms of diseases due to smoking. So smoking causes not only lung cancer, but also lung disease, heart disease, and contributes to other types of cancer as well. So this is really busy, but we're going to go through it. So first of all, this is our y-axis here is per capita number of cigarettes that are used per year, right? So per person per year, on average, how many cigarettes are people smoking? And so you can see, and as the book says, you know, it wasn't really a big deal until the early 1900s, and then it really took off, and Great Depression and life was really difficult, and people didn't have money, and then whoosh, right? Huge increase in smoking. It became hugely popular. And we started to see evidence of the link between smoking and lung cancer in around 1950. And then in 1964, the Surgeon General's report came out and said, actually, like, smoking is actually really bad for you. Like, I have to tell you, people used to smoke in hospitals. Not only did people used to smoke in hospitals, but doctors would smoke in hospitals. There was like a Camel ad. It was like the #1 cigarette favored by cardiologists, right? So I don't know why people didn't think smoking could be harmful to your health, but they didn't. All right, so 1964, we realized, okay, smoking is bad for you. We start to see all kinds of public messages, all kind of education, information about how smoking is bad for you. The Fairness Doctrine gets passed, which requires, you know, if they say something about like, oh, smoke these cigarettes on TV, then there has to be a message afterwards saying that smoking is bad for your health. And then then a couple years later, they said, you know what, actually, you cannot advertise cigarettes on television. It's just, they're too bad for people. We can't do it. But people were still smoking, right? So then we doubled the cigarette tax. Oh, that helped, right? Then we had the Surgeon General's report on secondhand smoke. So not only like smoking yourself, but if somebody smoked around you, so now like somebody else's behavior could impact your health. And we had really good data to suggest how dangerous that was. So then people started getting really involved because they're like, hey, this isn't fair for what you're doing to negatively impact my health. And so then nicotine replacement things became available over the counter, which made it a little bit easier for people to quit. Then there was a big agreement from a lawsuit that required the cigarette companies to basically pay money to the federal government, but it also banned ads in print. So magazines used to have all these ads for cigarettes, right? So they banned them from television, but magazines still had tons of ads for cigarettes. And so they banned those. And then, let's see. And this law was passed that gave the FDA power to regulate cigarettes. It also banned sales to minors, like for the first time, like it took us a long time, and banned things like vending machines. So, you know, when I was little and my mom would go bowling, if she didn't have a babysitter for me, she'd take me with her to the bowling alley. I'd hang out there. There were cigarette vending machines. Like that was just a thing back then. Okay. And then the other thing that happened is that smoke-free laws started being passed at the state level, starting in the late 1990s and then in through the 2000s. This is what the current map of smoke-free, or they're called smoke-free environment laws, looks like now. You'll see not every state prohibits smoking in all indoor environments. And this was really quite late, right? I just said late 90s to early 2000s. When I was in college, people still smoked in restaurants. People still smoked on airplanes, right? Yeah, there was a smoking section, but we're all in the same big tin can, right? So this is all relatively new. I know you're like, you're old, but no, it's relatively new. But look at the steep drop, right, that we see in cigarette consumption with all of these laws enacted, right? So this is incredibly powerful. And notice how so many of the things that seem to be most powerful are laws or obligations or requirements, not incentives or merely education, right? So there was lots of education, but you know, humans. So I'm going to just show you an example of the effectiveness of an obligation type intervention. So this is a study where they looked at the impact of smoke-free legislation in Scotland. So Scotland was the first part of the UK to pass comprehensive smoke-free legislation that said you could not smoke inside restaurants, bars, or workplaces. And England, during the same time, did not have that law. So Scotland passed one before England did. And so they gave them kind of a nice control group, right? And so what they looked at was the incidence of acute coronary syndrome, which is a fancy way of saying heart attack, right? So people going to the hospital with heart attacks, both before and then after that law was passed. And so what we see down here is the light blue is before and the dark blue is after. Hugely significant drop, right? It's not like heart attacks went away. There's lots of things that cause heart attacks, right? But a huge drop, and a huge drop right away. So overall, they saw a 17% decrease in heart attacks in Scotland. And during the same year in England, because maybe there were other things going on that decreased risk of heart attack, in the same year in England, there was only a 3% decrease, right? This is incredibly effective. All right. So I'm going to shift a little bit to something that I started to talk about previously. Figuring out the order of these is tough. So this is when an individual person's behavior can impact the risk of the people around them. So masks for COVID were a great example of this. And there was a lot of misinformation out there, and so a lot of people didn't realize this. But if somebody has COVID and they are not wearing a mask, me wearing a mask will help prevent that transmission, but it will not entirely prevent it, right? You can almost never entirely prevent it, right? But so that would be this kind of this is medium risk right here. So if they're not wearing a mask, but I am, it's still a medium risk thing, right? Masks are not, as we all know, they are not 100%. And so the safest thing by far is for the masked or the infected person to also be wearing a mask. So when I wore my mask during COVID, part of it was to protect me from getting sick, but a lot of it was just in case I was sick, I didn't want to spread my germs to somebody else, right? So this idea where my mask protects you and your mask protects me, and then also this idea of at the population level, if we're all wearing masks, then the likelihood of all of us, right, getting infected is much lower, right, for everybody, because there's just there are fewer COVID particles hanging around in the air if everyone is masked, right? So, people are like, oh, if masks are working so well, why are people still getting sick? And it's, well, because A, masks weren't perfect, and B, a lot of people still weren't wearing masks, right? I remember one of my students who we had to wear masks on campus, but she didn't when she wasn't on campus, and she ended up getting COVID. And the really devastating thing about that was that she worked at a nursing home, and she gave it to a whole bunch of the residents of the nursing home. And some of them died, right? So like your behaviors can impact other people. So this kind of brings up this question. And this is something that we struggled with mightily during the pandemic and still struggle with in a lot of different ways as a society. And it's an inherent conflict, right? How do we balance personal liberty, right? Which is a value that we hold dear, right? Your freedom to live your life as you choose, against the good of the community. And so one of the things that we saw also during the COVID pandemic was that if a lot of people were getting sick, our emergency rooms and hospitals got really full. And so you might say, oh, so what if I get COVID, if I get sick and have to be in the hospital? Well, that's on me. It's like, well, yes, but then if the hospital is full and I get in a car accident or something, or I'm having a heart attack, nobody's able to take care of me, right? So what we started to see happen was what we had feared, right? Is that our hospitals became overwhelmed. And so people died who otherwise wouldn't have because they couldn't get access to the care that they needed. So this was yet another way that one person's, people's individual behaviors impacted the health and well-being, not just of the individuals around them, but of their entire community. This was an extraordinarily stressful and traumatic time for anybody who worked in a hospital. If you know people who worked in a hospital during this time, you know this, but if you don't, you may not be aware. And can you imagine just being breakneck crazy busy, like all the time, nonstop, like twice as busy as you're just running around like a chicken all the time. And people are really desperately ill. I remember an ICU nurse talking about, like, we're used to seeing people die, right? It's critical care. We're used to people being really sick and dying, but not like this, right? People were just dying left and right, and it was really devastating. And because of that, a lot of people left healthcare, right? A lot of people quit and did something else. A lot of people took early retirement, and we have a terrible healthcare worker shortage now. We had one before the pandemic, but now it's even worse. So nurses, physicians, physical therapists, respiratory therapists, you name it, pharmacists, we don't have enough of them, and that's causing problems for everybody. So Oliver Wendell Holmes is a hero of mine for many reasons, but I love this quote of his, right? My right to swing my fist ends where your nose begins. So basically saying, I have the freedom to do as I please, as long as what I'm doing is not impairing your well-being or your freedoms, would be kind of an expansion of that. So what did we do at Stout when we were in the thick of the COVID pandemic? Obviously, that first spring of 2020, after spring break, we went fully remote. But that next fall 2020, we reopened and we had in-person classes. But there were a lot of obligations in place. Everyone had to wear masks when they were on campus. You had to social distance, so we had to move into different classrooms and things. I taught a class in Harvey Hall Theater so that it would be big enough so that everybody could be sitting 6 feet apart. So that's social distancing, and you had to get tested regularly. regularly. I can't remember, once a week or twice a week, but you had to get tested. Like you had to like sign in with your ID and like get tested, so that we would catch anybody who was positive. And then if they were positive, they had to go into isolation, and that was an obligation. We were putting people up in area hotels, right? If they were in the dorms and they had a roommate, and so we needed to isolate them. We did have incentives for people to get vaccinated. We also tried to make it easy for people to get vaccinated by having clinics, vaccine clinics on campus. And then there was tons of information that went around. So all different types of interventions, all different types of strategies, both primary, secondary, and then tertiary. We had at health services, we took care of people who were sick with COVID, of course. And then, but this was all for everybody, really. This was enforced for everyone. So that's implementation. So when, so primary, secondary, or tertiary interventions, who, everybody, those most at risk or those most likely to get a high net benefit, and then how. So that information, education versus incentive, motivation versus obligation or requirement, and always trying to balance personal liberty and freedom and autonomy versus effectiveness and the well-being of the community, which is very tricky. All right, so now we're going to move into evaluation. So this is the final part of our PERI process, and I've been doing a little of this all along as we go, so this part is not going to be very lengthy. I'm sure you're happy to hear that. So evaluation, how's it going and is it working, right? So the book uses this RE-AIM mnemonic. I like it. So R for reach, is it getting to where it needs to, right? So are we actually getting vaccine to the people who are at highest risk? My mom was in Florida at the time, and Florida had their health departments were having a heck of a time rolling out COVID vaccines when they first started. It was very frustrating. Effectiveness. Is it working and not harming, right? So again, constantly evaluating the effectiveness of our recommendations and our interventions. Like, is it actually doing what we thought it would? Is it causing excess harm, right? Finding out about those blood clotting events with that one COVID vaccine, looking at the myocarditis data, making sure benefits still outweigh the risks. Adoption. Is it being utilized and used? Now, this is related to REACH, right? But then, like, are people actually doing it? So I didn't wear my seatbelt as a kid until the law was passed and I had to, right? So are people actually doing the thing that will be helpful for them? Implementation, right? How do we get it to the target population? I think they use I because they like it for the mnemonic, but I almost think of this more as like operations, like operationally, how do we actually make sure that we're doing this efficiently? And then M, maintenance, how do we keep it going? So just to give you another little example, sticking with COVID, this is a graph that looks at vaccination rates in those aged 65 and up and mortality rates. So what we see down here on the x-axis is what percentage of people aged 65 and up are vaccinated against COVID. And then here are your death rates, your mortality rates for people aged 65 and up. And what you can see is a clear linear relationship. The higher your vaccination rate in this group, right, the lower your death rate, the lower your vaccination rate in general, the higher your death rate. Now, West Virginia is definitely an outlier there, right? Pretty rural population, not a lot of big cities, so it's harder for a virus to spread. Maybe that's part of it. I don't know. That was just a distribution of disease hypothesis I generated right there. So I'd have to do further data to figure it out, right? But obviously, right, not everybody is adopting, right, these measures. So these are the things that we look at. Okay. So for Unit 2 then, the evidence-based public health approach, problem, etiology, recommendations, implementation, and evaluation. Here it all is on that same slide that you saw at the very beginning of this unit. Now, hopefully it all makes sense. And I hope you're excited to, learn this and be able to understand why some of the things that you've been seeing happening out in the world have been happening and bringing a new critical lens to them. All right. Thanks, everybody. See you next time.